Hello, my name is Cunningham. I'm an Associate Professor in Immunology at the University of Brunei Darussalam, and I'd like to share some thoughts that I published in Critical Care in the middle of March. So really looking about how can the immune system help this current situation, and is there anything from the past that we can learn and apply to this pandemic challenge? And the key question really is, can we take plasma from patients who've recovered from the disease and use it to treat those who are critically ill? So the reason that I was moved really to write this is by seeing this kind of chart. So this is a dangerous new virus. We don't know really very much about the biology. As you know, it emerged in Wuhan, probably December 2019. And the thing that was very clear about it is it was highly infectious. A lot of people are infected. I wrote this article just over a month ago. There was just over 80,000 cases. Now we're up to 1.6 million. So it causes severe problems in about 20% of people. And at the time of writing, death rate was around 2%. Still difficult to estimate what the death rate is. But the thing that really struck me was the number of recovered patients. So this, if you like, is an amazing resource that could be used to help the critically ill. The other thing about this new virus is there is no treatment. Most people don't ever receive any treatment when they fight a viral infection. And in this case of this disease, most people recover. So it's clear that we can make an effective immune response that can recognize and destroy this virus and destroy the virally infected cells. However, a proportion of people, maybe 20%, need to go into hospital. And of those, a subset of them become very critically ill. And this is characterized by a fall in their lymphocytes, their white blood cells, and an increase in pro-inflammatory cytokines, sometimes described as cytokine storm. So this can lead to lung injury and organ failure. So what can a clinician do? At the moment, the management entirely focuses on supportive care, oxygenation, ventilation, and fluid management. And the aim really is just to give time for the patient to recover so that own body can fight the virus and get better. So really what we can see is our immune response to this virus is essential for recovery. And we can recover, so we can make an immune response. So how does it work? So this is the virus. All viruses are intracellular parasites, and they can only replicate inside host cells. We've got many immune responses to fight viruses, and they fall into two sections. They can be innate, the first line of defense. The first wave is called the interferon response. The second wave is the activation of a special subset of cells called natural killer cells. Here in yellow, you can see the amount of virus over time. So you can see the virus goes up, and the innate system can hold things at bay. But ultimately, it's only the adaptive system that can destroy and get rid of the virus. And really, to get rid of your virally infected cells, you need specialized white blood cells called T lymphocytes to kill them. Antibodies can also contribute to the killing process. So it's desperate times, desperate measures. So many things are being tried around the world by clinicians to help these very seriously ill patients. So we do have antiviral drugs. The very first antiviral drug, ganciclovir, was developed more than 30 years ago. But more recently, in our fight against HIV, we have a range of drugs that target different parts of viral life cycle. So HIV is a different kind of virus to this virus, but there does seem to be some evidence that some of the anti-HIV drugs can be helpful against the virus that causes COVID. There's been a lot of information about using the anti-malarial drug. So again, the evidence isn't strong, there's not much data yet, but there does appear to be some benefit in terms of antiviral and anti-inflammatory activities, but there still isn't good clinical trial data to prove this. This virus started out in China, and there's also been many Chinese trials looking at traditional Chinese medicine. So really, everybody's just trying to think of everything. So what about passive transfer of preformed antibodies? This is tried and tested and physiologically relevant. So during pregnancy, a mother will transfer antibodies to the fetus. So by the time of birth, the amount of antibodies in the fetus is the same concentration as in the mother. Antibodies obviously have a half-life, so over time, the colostrum and then the breast milk contain the mother's antibodies, and this provides passive immunity to the newborn, and that enables the immature immune system of the baby to begin to develop until they make their own antibodies. And we call this passive, and also we've used passive immunization in disease settings for many hundreds of years. So before we had vaccines, or we were unable to have a particular vaccine for a particular disease, we used to use something called hyperimmune serum or immunoglobulins. So we use this still to treat immunocompromised individuals, and there are a whole range of plasma products that exist. So usually these are what we call polyclonal, so they contain a real mix of antibodies, so they would reflect what is happening in a normal immune response. So if you want to know anything about vaccines, the best source is called the Green Book. This is published by the British government. Here is the web link. And within that, chapter 1, how do vaccines work? Immunoglobulins are given as part of the passive immunization process for a whole range of diseases. So for example, before we had a good vaccine against hepatitis B, we used to use immune globulins specific to hepatitis B to transfer to patients. So what about antibodies? What are antibodies? So there are 5 classes of antibodies. IgM is the biggest, and it's the first one, and it's mainly found in the blood. It's difficult to travel into tissue. IgG can be described as the workhorse of the immune response in terms of antibodies. It's the main antibody that we find in blood, plasma, and it's small, and it can get into the lungs and all the spaces in between cells. Probably the most common antibody that you have would be IgA, but this is found at mucosal surfaces because pathogens come in from the outside. They come in through your mucosa, your lungs, your gut, for example. So you have a lot of IgA, but it's just not in your plasma. It's in your secretions, your saliva. IgE is very specialized. You've probably heard of it in the context of allergy, but it's also very important in fighting bacterial infections. IgD is another antibody. It's not really expressed. It's more of a control antibody, and it's found on the surface of some cells. So the main classes of antibodies you've probably heard of are these 4. These are the structures of the antibodies, and you can see that IgG is quite small and IgM is big. So this has a difference in both how well they can bind to viruses and how they kill them. So these are the different classes of human antibodies. This is the weight of them. So you can see IgM is much, much bigger because there are 5 antibodies together. These are the serum levels, normally mg per mil, and how long they last. So they last between up to about 3 weeks, half-life. IgA mainly in the mucosa. IgE mainly in connective tissue. So in terms of the blood, it's IgM and IgG, which is shown here. Okay, serum, IgM and IgG. What do they do? So antibodies are very important effector molecules. They have amazing properties. They can both recognize with high specificity and also destroy pathogens like this virus by a whole range of different methods. So these are the different antibody classes and some of their functions. So opsonization means that it coats the pathogen, and it can be gobbled up by phagocytes like macrophages and neutrophils. Complement is a very effective way of killing things. Neutralization is very important when we think about antibodies. So we can see IgG, IgA, very important classes of neutralizing antibodies. So this will neutralize, block the virus and prevent it from entering cells where it can take over and start replicating itself. So when we make an immune response, the first antibody is IgM. And then when we make a secondary immune response, if we see the same thing again, we're immune, we make lots of IgG. So with coronavirus, we don't know how long it takes to seroconvert. So with the SARS, it was maybe 3 to 5 days before you saw any IgM, maybe longer before you see IgG. So many more studies need to be done. So this is part of what we call the adaptive immune response, and it's only lymphocytes that do this. And lymphocytes ultimately are responsible for getting rid of the virus. Okay? So this is just a diagram to show the various ways that antibodies contribute to the recognition and destruction of pathogens. They can neutralize them, they can block them, they can activate effector mechanisms like complement, like phagocytosis. They can stick them together. Okay, so antibodies are very powerful in our arsenal of making effective immune responses and keeping us well. So, does it work? If we transfer antibodies from one person to another, can it help fight disease? So there was a very big, quite a big systemic review done on respiratory infections. It did include some patients with SARS, but most of the studies were done with influenza. And generally, a protective effect was found, and there was no adverse events. So certainly for influenza, passive transfer of antibodies has been used for more than 100 years. Few adverse events have been reported. Timing is important. So the biggest study that's been done on coronaviruses was done on SARS, and this was done in Hong Kong during a previous outbreak and was published in 2014. So there were 80 patients, and what was really interesting about this study is that the time that you give the antibodies is important. If you give the antibodies before day 14, there was a good outcome. If you left it too late, there was a poor outcome. So here we can see mean day of plasma infusion, 11 and 16. Okay, so lots of people have been interested with coronaviruses to look at this passive transfer of convalescent plasma as therapy for the very critically ill. And a number of trials have been planned, but the issue was that the epidemics never got big enough to be able to get enough patients to be able to donate large amounts of plasma. So at the moment, as of today, there are over 350,000 recovered patients. So there's a huge number of people who could donate plasma to help the very seriously ill in intensive care. What about the risks? So of course, if you give plasma, there are bound to be some side effects. One of the classical ones is what we call serum sickness, where when you're ill with a viral infection, you often feel that achiness, and this can be transferred by antibodies. So again, looking at a a meta study, a summary of other studies a few years ago. So hyperimmune globulins are used widely for a range of reasons, and though the risks are quite low, the largest would be a same-day thrombotic adverse event. So none of the smaller studies looking at influenza and SARS have particularly shown adverse events. They tended to show benefit, but if you look at many, many more cases, so this is a 3-year period of any antibody products, you can see that there are some adverse events. And there is, of course, some risk that you would make things worse. but it seems quite positive. So what about the other considerations? If you're going to use a plasma, it's a biological product. We need to know who would be a good donor, when would be the best time. So how long after they've had the infection will they have developed high quality antibodies that can recognize the virus, IgM and ideally IgG. Obviously there has to be a process of informed consent, and it has to be all done within an ethical framework. Blood transfusion services know how to do this. The method of plasma apheresis is quite common. So when you get the plasma, then you have to evaluate it. So these are not monoclonal, highly defined products. These would be very, very variable and different. So they would contain a real mix of antibodies. So we have a number of different technologies which can identify how many specific antibodies you have. So that's one, but also what do they do? What's their function? And I think particularly for this virus, people are interested in their neutralizing antibody levels. Some studies use fresh plasma, and then you can also use frozen plasma, which should probably be okay. So you also want to know which patient do you choose, when is the best time to transfuse them, how much plasma do you need to give them? Is it one? Is it multiple transfusions? And a number of different methods have been tried so far. So in terms of monitoring, we want to check what are the antibody levels in the patient before transfusion and after transfusion. What effect does this transfusion have on viral load and other parameters of the immune system? So in the seriously ill with COVID-19, what tends to be observed at the later stages is that the lymphocyte counts fall and the cytokine levels rise. So you want to see a reversal of that kind of pattern. So what's been done so far? When I wrote this, there were some news reports that they were beginning to take convalescent plasma from patients in China. And so as of today, which is the 10th of April, there have been 3 studies published. So on the 27th of March in JAMA, there was 5 patients. They received 2 lots of 200 mils, and they saw good results, viral clearance and patient recovery. On the 31st of March, again from China, 4 critically ill patient case reports are presented. And this was used as a last resort to suppress viremia. No adverse events, and out of those 4, 3 had been discharged and 1 remained in hospital. And the most recent study, published just a few days ago, was a pilot study published in PNAS, 10 patients. And again, transfusion was associated with an improvement in symptoms and a reduction in viral load, and again, no adverse events. The problem with all of these studies is that they're very anecdotal. These patients also received a very complicated mix of antiviral medication and other treatments. There's not much consistency necessarily in the amount or timing of the plasma, so there really needs to be better quality data. I think it's quite hard when you have very ill people and you want to give them something that works, but more studies have to be done to know exactly what are the parameters to best give this, to get the maximum benefit for more patients. So the latest news is that the FDA has approved the use of convalescent plasma, and you can have a look at the guidelines. So you can get the document from their website. So it can be used for an individual patient, the start of a clinical trial. So I presume that in the near future, some good quality studies will be performed to evaluate the role of convalescent plasma in COVID-19, particularly the very critically ill patients. So it's interesting that the idea I had is not really rocket science. It's an obvious idea to an immunologist, and it's really just to remember that this is something that has been used before and it's something that works. So you can read more commentaries from other authors with more detail, and this is one that's just been published in the Journal of Clinical Investigation. So finally, this is me. If you've got any questions, please drop me an email. I'm passionate about teaching immunology. I've written a textbook for my undergraduate students, biomedical science, medical and dental students. So if you want to have a look at a simple revision book, maybe you can have a look at that too. I hope you found this interesting. Thank you very much.